Good morning and welcome to the Health and Adult Social Care Scrutiny panel. Apologies for absence this morning. We've got Councillor Zaman and Peter Bradshaw, and we welcome a new co-optee, Lynn, to the committee. Welcome. Anybody got any interests to declare that are on the agenda? No? Admission of the public, all debates are in public this morning. Item 3, transforming outpatient care. We have Lisa Williams and Anna Basford from CHFT who are going to talk to us on this item. So you've got a presentation, but please leave plenty of time for questions because we have lots of questions as usual. Thank you.
Okay, thank you very much. I'm Anna Basford. What we shared with you ahead of today's meeting is a report which you'll have had opportunity to read. I thought it was helpful as a way of leading into your questions and discussion around this, just to set the scene a little, and I have a few slides to support that, and I will keep that brief. So if we just go to the first slide, thank you. Just the background to why we're undertaking a programme around outpatient transformation is outpatient services represents a huge proportion of the services that we provide as a trust, and we have a significant number of people attending the hospital every year, and I've indicated that volume coming up to clinics at hospital. We know that during 2017, Healthwatch undertook a survey of the public, and there was an overwhelmingly positive response from members of the public that they would welcome alternate ways to be able to access the care they need without necessarily having to take a journey to hospital every time. Included within that in their survey was also that there was a considerable appetite to explore the use of digital technology, online consultations, and the ability for patients to have choice about how often they attended rather than necessarily having prescriptive routine follow-up intervals. We also, on the back of understanding the views coming from members of the public, have had dialogue with colleagues within the Trust to look at what opportunities are there around the delivery of care. And again, many of our clinical colleagues have expressed that they can see better ways to deliver outpatient services that would improve the experience for patients, their outcomes, and make a more efficient use of our resources. We know that by delivering these services in different ways, as I say, there are massive qualitative benefits, but you'll also know that we are a health system that is significantly has significant financial sustainability issues, and maximising the use of our resources is also important. In terms of, if we go to the next slide, wider context, we're not exploring the transformation of outpatient services in isolation. It's not something unique that CHFT is doing. This is something that's been recognised at a national level by both NHS Improvement, NHS England, and the Care Quality Commission, both in terms of the quality and the efficiency benefits that could bring. Across the West Yorkshire Health and Care Partnership, this has also been identified as a major ambition to be able to appropriately reduce the necessity for patients to attend hospital, potentially with a stretch target for a 20% reduction in the number of outpatient attendances required across our region. If we go to the next slide. So, I've talked a lot about reducing services, and one of the things I want to make really clear, this is not about cutting services, and it absolutely is, first and foremost, about improving patient experience, patient choice, and the outcomes of care. So I thought to bring that to life, it was useful to just indicate to you that this is also not a prescriptive programme, so we're not saying it's a one-size-fits-all. We're very much aware the services we offer and the patients that need those services are not one group. People have different needs, and we need to design how they access services appropriate to meet their needs, which means we're looking at a range of options and exploring those with clinical colleagues and with service users. So in every area where we're looking to undertake a redesign, we're actively bringing together service user groups to inform that. So we have a real detailed input around that particular service and patient's experience. So if I just take a couple of these to bring them to life, because you'll hear the terminology, and I think it's easier and helps to just if I give you some examples. So the first one around virtual clinics or MDT, multidisciplinary team reviews. These are examples where instead of a patient needing to come up to hospital to see a consultant, maybe seeing a doctor for 5 minutes, it may be possible actually to support that individual's care without the need for the patient to be seen at all, but by booking essentially time slots where the appropriate clinical team, perhaps a multidisciplinary team, review the patient's care, perhaps look at available information in their electronic record regarding test results around their care, to be able to give advice which they may give back to the GP around ongoing management in the community, or they may, as a result of that, directly communicate with the patient. The other area is around online or telephone consultations, and that's talked about a lot, but for some people that could bring a real benefit to them. We know we have examples where there are people that may spend nearly all day travelling to hospital using patient transport services, getting up early in the morning, coming into a clinic setting, and essentially they may spend a relatively short amount of time with the consultant or the doctor they need to see to do that round trip home again. To be able to have that consultation in their own home or in a community setting could really give them a better experience. It may be more convenient, it may mean they don't have to arrange childcare, take time off work, but also some of the use of that digital technology can actually support some of the more vulnerable members of our population. For example, where people want to be supported by a family member who perhaps doesn't live locally, lives in another part of the country. Through digital technology, daughter, son, friend can be connected into that consultation and visually be seen interacting and be able to support their patient, their loved one, during the consultation. We also know for some of our services, we do still have occasions where people are referred to our services where actually their needs could very ably now be met within primary care or within community services. There is more work for us to do around colleagues within the hospital working with community-based staff around education, around referral pathways, about when it's not actually necessary for someone to come to hospital and their ongoing management can be supported in the community. The other areas, such as straight-to-test models, we do have some services now where you could have an experience of coming up, seeing a doctor, identifying that some tests are needed, going home, coming back on another day, having the tests done, going home, coming back on another day to get the test results, to then find out the appropriate treatment and course in action. What we're looking at is the opportunity to redesign that, where there could be potentially just one visit, do all those consultations, get the test results on the day, better use and effective use of resources, better use of time for patients, and more convenient. And that fits a lot around the one-stop model, would be in keeping with that straight-to-test model. We also are looking at what we're calling patient-initiated follow-up. So this is for people who might have a long-term condition, for example, diabetes, respiratory conditions. And what we may do at the moment is say, I'll see you in 3 months routinely. And of course, in 3 months' time, people may be very well. They may be very well managing their condition in the community. They might not have had any exacerbations, but they still come up routinely to tell us that they're feeling very well and everything's going fine. Patient-initiated follow-ups is about designing pathways where a patient who knows their condition well, has perhaps lived with it for a long time, they know if they're starting to feel unwell and when they may need extra advice and support. And it's having a pathway where they can fast-track straight back into that contact and take out all the potentially unnecessary routine appointments, but that they can access the appointments they need when they need them. And then also, within all of those, looking at the appropriate skill set. And when is it beneficial to see a doctor? And you absolutely need that skill set. But when could specialist nurses or therapists equally deliver that care, which could reduce waiting times, improve our capacity within resource? So those are the examples of the work we're doing. And if I go to the next slide. So what I've framed for you there is public appetite for change, clinical colleague appetite for change, some knowledge about the redesigned type of opportunities. So what we've done is structured a programme to say, actually, we think this is a major programme of change that we'd like to implement, and we need to do that in partnership. And I've already talked about the importance around the partnership between clinical colleagues and service users and members of the public, but with our wider partners across the health and social care system, which is why I'm very grateful to be sat here talking to you today, But you'll see we've put together what we're calling a transformation board. Essentially, it's the oversight group of our programme of work, and we've got representation from across secondary care, GP practices, clinical commissioners, Health Watch, and some of the members of our Council of Governors, and looking for some lay voice within that as well. And what I do want to say is, because it's not a one-size-fits-all, and we might be redesigning particular services unique to the needs of those patients in that group, every change that we want to move forward is subject to a rigorous testing around a quality impact and quality impact assessment before we would sign that off. If I go to the next slide, at the start of this year, when we started the programme, we wanted to give some structure to it, so we thought about where would the initial priorities be, where we'd want to start doing this work, and that's shown on this slide, and we highlighted some specific service areas. But if I go to the next slide, which highlights how we've been supporting this with a wide level of engagement, talking to many clinical colleagues, service user groups, and health and care leadership groups across the system, what we've found, and again if I go to the next slide, is that this has started to generate interest. So as well as the schemes I've highlighted on this slide and which were within the report, these are the schemes that have been identified that we're currently progressing, that we've assessed the impact of and we're taking forward. There is, on the last slide, a table which is very difficult to read on the slide, but hopefully was more readable within the report. This is where people have self-generated ideas and said, could you have a look at this? So we're starting to build some momentum where there seems to be, as I say, a considerable appetite for change, and we believe we're starting to put in place a programme structure to enable us to take that forward. If I could just go backwards to the preceding slide, Richard, thank you. And just to bring to life the words on the slide, I'll take one example on there. The urology one-stop model for prostate cancer that we've implemented, that is about patients coming straight up, being able to have their tests and their consultation in one visit. We know that that will significantly reduce overall waiting times from GP referral into definitive treatment for cancer. And that's just one example of the benefits, and there are equally benefits across this whole range of schemes that we're implementing. And if I just skip over to the last slide. So in setting the scene, I hope I've framed what the work is, what we're trying to do, and I'm very happy to take questions and have discussion and interested in your views of where you may see opportunity for us to take this further.
Thank you very much, Anna. Right, questions, Dave.
Morning, thank you. I very much support the objectives behind this, but I think it would be helpful to have a bit more sort of flesh on the bones. Just turning to Appendix 1, there's a reference there to no unnecessary appointments. It's perhaps a bit surprising that there are currently unnecessary appointments and why that hasn't been tackled previously. No delays, quick tests. I wonder whether there's an implication there for staffing. If your tests are going to be quicker, you need more staffing to do that. And similarly with strong clinical leaders in each speciality, does that have an implication of additional staffing? Obviously there's a financial background to this which might make that difficult, but also there's a shortage of strong clinical leaders nationally. So if you could just say perhaps a bit more about that. Thanks.
Okay, I'll start and Lisa may add to some of the comments that I'll make. One of the things I will say, I started off by saying this isn't about making cuts in service provision. It also, quite rightly as you're saying, we don't have funds to invest into this. So we are looking to build an engagement and momentum where we're identifying natural champions for change. And what we're finding within the services, when we say strong clinical leadership, by going into dialogue with clinical colleagues about how currently clinics are running, where they see opportunity to improve that, they are enthusiastic to make the change. They are frustrated by where they perceive there are inefficiencies in multiple attendances, if that could all be done in one attendance for a patient, and the way those clinics are structured. So we're certainly not thinking that we need to recruit or support additional clinical leaders. We're looking to really work with existing champions, and that's, you'll know that champions for change are not always in your formal structures. You can have very passionate leaders for change within the workforce that need to be given that opportunity and that dialogue. And that's what we're doing through this scheme, is wrapping around them some governance support, but also some management infrastructure. And that's us prioritising in the trust some of our support that we have for service redesign and change, and wrapping that around to make some of this happen. In terms of unnecessary appointments and no delays, we don't have fully optimised outpatient clinical services across the board. There are further changes that we can make, and those are the opportunities that this scheme is recognising. So you're right when you say somewhat surprised that there may be unnecessary appointments. The example I just gave you around that there is a custom and practice, isn't there, to routinely, we perhaps all know people that go along and have an appointment, and it's I'll see you again in 6 months, I'll see you again in 3 months. And actually, with some support such as patient-initiated follow-up, or some greater advice, or the ability to actually maybe not need for that patient to come up to hospital, but perhaps to have a telephone conversation in 3 months, maybe an alternate way to appropriately deliver that care.
Thank you. You spoke about digital care and maximising your resources. I am really worried about digital care and at what point you implement it. We speak about cardiology, neurology, breast cancer, and all those sections where you want to implement it through. We're in a state where we have an ageing population. Having to make those changes for somebody at that vulnerable stage. At what point are you actually wanting to kind of implement virtual kind of? I mean, I as a counsellor, I do virtual clinic surgeries, so I'm all up for the new way of doing things. But there's at some point there's a definite place where you can do this and when you can't. So if it's in the first initial stages, yes, okay. But that also might mean that if as a cardiac patient or something like that, they may not be describing their symptoms as best. Visually, it's different. Again, the same for breast cancer and prostate cancer. And I'm speaking to somebody who was family in the medical field. So I'm just basically, at what point are you wanting to actually implement that in kind of thing?
There's no one size fits all, and we're not going down a route of saying that in one specialty all care will be delivered digitally, because we know that doesn't work for every patient. We've taken some learning from the North West and other areas such as Wales and the North East that have implemented digital care and patient-initiated follow-up and several other areas that we're looking at to see where it works, where it doesn't work, what's the evidence base. Talking to some of our consultants and clinical colleagues, they know their patients quite well. So, such as cardiology, I had a conversation with one of our cardiologists and said, would you like to try virtual clinics? His view was, no, I don't feel that that's appropriate, because if I need to see a patient, I need to physically put my hands on that patient. If I don't need to physically put my hands on that patient, there may be alternative ways of doing it that isn't via a video link. It may be that it's more appropriate for a nurse specialist to do that. It may be telephone, or it may be that we do a virtual MDT and the patient doesn't need to be there. But that will be different for every patient given their circumstances, their social circumstances and their physical ones. Respiratory, there's certain conditions in respiratory that this would never work for, because you need to physically see those patients to see how they're breathing, how they look, what their skin condition's like, how they can mobilise. But then there's other conditions, so some of the surgical conditions where I have a consultant who is chomping at the bit to try virtual online clinics, because he thinks that that is the best way forward for his cohort of patients. We did talk to a consultant in the North West who's doing it for stroke patients, which was quite surprising for us, because it wasn't an area that we thought that virtual online consultations would work. He's found that that has taken off tremendously, but he's got the backing and the help of the Stroke Association and the carers groups. And what he's found is that if there are patients who are unable to use the technology, don't have access to the technology, quite often their family members are taking them into hospital, and it's easier for them to be able to do that with a tablet, with a phone, in a patient's home. But also the Strokes Association have been going in and supporting those online consultations, and his clinics have evaluated really, really well.
Thank you. In terms of the MDT, is that when, tell me if this is right, with cardiac patients as well as patient care checks, it's when there's a particular recorded service to actually record the beats from a telephone system or a recording system as well. Sorry.
Recording the what, sorry?
I was just trying to basically, in terms of the cardiac visual care that you're wanting to propose to take forward, is this where you have a particular recording service? I mean, I've read about this, and obviously, so there seems to be a device where patient's respiratory system is basically monitored, and I think some GP surgeries have this as well. When nurses cannot obviously do the whole thing, it's basically recorded or connected through to another system. And tell me if I'm going somewhere completely wild with it. I'm sure it's not a made-up thing. I've definitely read about it. And is that the line that you're wishing to take?
We haven't gone there yet. There are different systems that you can use, different apps. We haven't explored that yet. We would like to explore that in the future, but it's not something that we're looking at. It's baby steps. It's not something that we're jumping straight into. There are one of the things that we are looking at is better access to devices where you can record over a certain period, but there are existing devices that are used at the moment that are called like 72-hour tapes, 7-day tapes, where a patient has an ECG monitor on. It's just better access for that. So we're looking at, can you access that in primary care rather than having to come to the hospital? We haven't gone down that road, but I do know what you mean.
I'm glad you didn't think it was me, not in any way whatsoever. And just sorry, the final bit is with all of this. I mean, like I said, I like the digital bit, but I'm a bit skeptical. I'm quite skeptical, especially with mental care patients and obviously patients that are not flagged. You know, we're not obviously as the mental care patient or mental health patients, but they still need to require that bit, and I'm thinking they might not be able to access those facilities or those services.
As I said, it's not one size fits all. We will assess those patients, and if they need to come to hospital, that service will be there.
I'd just like to ask a question with regard to children. You're saying that children will be able to receive advice at home with their family, which is likely to be preferable to attending hospital. But I'm sure, if unfortunately, if you had an instance, which you will have, where children are on this receiving digital care, and then it transpires that they actually do need an operation. Wouldn't it be better, because obviously going to hospital is very daunting. So if they're going for outpatients appointments at the hospital, they're getting used to that hospital environment rather than just being dealt with at home, then being told, right, you've got to come to hospital for an operation. I would imagine that would be much more frightening for a child than actually gradually being, able to get used to that hospital environment. I mean, has this been considered?
The conditions that we're looking at, paediatrics at the moment, are the ones that are chronic illness or medical conditions rather than the surgical conditions. I fully agree. Children need to be used to a hospital environment. It is a scary time for them. This is more around the chronic conditions where it affects children where they're school age, and it's taking children out of school, taking parents out of work for numerous appointments that are a routine appointment. What our paediatricians are also looking at is doing things such as podcasts and video blogs, things like that, to say, I think I can call vlogs or something like that. You can tell I'm really up with social media. But doing things such as vlogs to give advice and guidance online to parents about conditions that they may constantly go to their GP with, because as a new parent, I've been there myself, you do go to your GP with things, but also for some of the long-term conditions that we have with children, where they can just access a video that reminds them of the advice that may be being given in a consultation, whether that's online or an actual consultation.
Right. So if a child, so it's up to the doctor then. It's if they've been to the doctor and they're, it's something more serious than just watching a video, then it's up to the doctor then to make that judgment call and then fast track them into a different.
Absolutely.
Okay. Thank you. Okay. Thank you very much.
Can we ask a few questions? We've been talking about videos and virtual consultations and things like that. So this will depend on people having the technology to be able to do that. So what about security of information across these links? Will it involve somebody having an account, or how does it operate so that people feel safe using it? Because you're talking over a link on the web, presumably, about personal information. So how are we looking at security of that information?
The video consultations that we're planning to trial are not done over Skype, they're not done over FaceTime. It's a system that's approved by the NHS that's been purchased.
Okay. Alison, did you
Yes, I'd just like to ask another question with regard to accessing the system. How easy will it be? Because, I'm sure a lot of us have had experience with dialing 101, and you have to wait for hours to get, it could be up to an hour to get a phone call back. So I just wonder how easy it's going to be for people to access it. Thank you.
I've seen a demonstration of it, and it's basically, it is very easy once you've logged on. And what they will have to do is patients will be sent a link. You click on the link and it downloads something onto your phone or your tablet or your laptop. It installs a piece of software, and then for future consultations that's there. It is really easy. It takes minutes to set up.
Could I just, on some of the technology and the use of technology, we'd be very happy to arrange, if members of the panel did want to perhaps undertake a visit to demonstrate some of this technology, but also then to have in the room some of our technology digital experts who might be able to answer more fully some of the questions you might have arising from that. So that might be something you want to think about subsequently.
Can we just be clear, though, that what you're saying is somebody would have an appointment? Yes. So somebody would be sent an appointment to download the link at that time to have that consultation. So there'll be a letter goes out.
The feedback that we've had from other areas that have done this, from our consultants that have used this technology and this type of outpatient system in other areas, and from patients that we have checked this out with, and they've said they want it to work on an appointments basis, just like a clinic, and we would log that as a clinic. So there would be a consultant doing a clinic just as he would. It would just be the patients wouldn't be sat in front of him.
Thanks. Excuse me. You mentioned before about one-stop shops. Now, you touched on the example within urology of prostate cancer. Perhaps just looking at how that would work in practice. So I think there's a stage-by-stage process where initially, if we're talking about this location, you'd be seen at HRI initially, and then further down the line you might have an appointment in Bradford, and then your treatment might be in Leeds. So perhaps it's important to define whether it's a one-stop shop across the piece, or whether it's the first bit that's a one-stop shop and then there are different locations, because it could be misleading otherwise.
That's a helpful point to make. We are talking about making it one stop for the elements of that service and journey pathway that we deliver.
Can we talk about capacity and demand now, please? And then I think we want to get onto consultation and engagement, I think, as well. So you need to reduce by 20% by 2020. That's your aim in this particular programme of work that you're undertaking. But are you looking, while you're doing this, are you looking wider than that? I know in the Mid-Yorkshire area, in the North Kirklees area, the Meeting the Challenge report that's gone to their board indicated that they had higher than planned demand for outpatients from North Kirklees. And with people being able to choose when they get a referral from the GP where they wish to have their outpatients appointment, where they should have their treatments, I'm wondering if you've considered that wider demand across Kirklees as well, and how this can help, and also hospital avoidance in all of this as well, because the projected population figures for Kirklees as a whole steadily rises. I mean, we're up to 437, well, just over 437,000 now in Kirklees, with a third highest in West Yorkshire. And for the Greater Huddersfield side of things, it's predicted by 2026 that we'll be up to 254,700 in population, which is higher than the Calderdale population. So I'm just wondering if you've thought about as well where the outpatients would be able to best provide the services within your trust, the impact from other areas as well, the demand, how you can help the demand, being able to choose where to go, and also about trying to reduce that demand overall for longer by hospital avoidance. Is this just a changing for now, or is this a changing for future as well?
In terms of that question and that breadth of question, the target of 20% is a stretch target, so I can't point to a science evidence base, and it's not a target that's been set for us in the sense of some of our other national mandatory targets. So it's a development target, and I think it's more indicative of the scale of change and opportunity that we think might be possible through the approaches we've described. We are very aware that there has been rising demand for services, and therefore our ability to continue to meet that demand within existing resources is really important, and this programme may well enable us to be better able to do that. The measurement of an absolute reduction in demand will be complicated because of that rising population growth, and also around an increasing reliance of an elderly population as well. So we don't at this stage have the answers to all those questions. I think that the context you describe is a context that we recognise. There is an additional complication, as you know. Well, it's not a complication. Patients currently can choose to go access outpatient services at any hospital, and we know that quite often waiting times is a factor. So as you improve, one of the benefits of making changes in some of our services is that we may be able to offer shorter waiting times for first appointments as a result. That may make us more attractive to a wider population. One of the things that I can say, though, through that choice of which hospitals people attend, there would be a flow of funding that would come for any out of area. So it would be about a shift of resource potentially out of one area into another area. So they're factors that we're very aware of. The modelling work, we've started this work and we've focused at the moment really around the engagement, the appetite, and a real focus around the energy that we're generating by people seeing that how the improvement for experience and outcomes can be delivered. So I recognise and apologise that's not a full answer around some of the quantification of the metric, but it's an area that we'll continue to work on.
Perhaps you could get back to us with some information on that. But the figures indicate that the number of people with limiting long-term illness is is rising as well, and therefore that would go more to the demand as well, wouldn't it? Also the capacity in the GP primary care arena, because people are going more from the GP straight into diagnostics, etc. And presumably when they've had those diagnostics, the results go back to the GP. So what about the capacity in primary care and the waiting times for people to be able to get that information as well? How are you looking at that in conjunction with the CCGs?
So this programme we've very much designed is a partnership with clinical commissioning groups in Huddersfield and in Calderdale, and also with the 2 GP federations in Huddersfield and in Calderdale, so that they're actively involved to have primary care input into the design of new pathways, and that we understand that if that means that there is a change in the services that need to be delivered in primary care or additional support, that the redesign is looking at how do we shift that resource to enable that. So we don't have new monies to invest. But if, for example, people attend, there's a requirement for fewer attendances into hospital. And if, supposing that is a service where we are currently reliant on delivering the capacity we currently have by employing agency staff or locum staff, we have the ability to exit that cost and to redeploy some of that money we're currently spending in the hospital into primary care. It may be an equivalent cost and then a cost-neutral development, but it's a better experience and quality for patients. Or in some cases, it might be a lower cost, the investment needed, which would generate efficiency savings for our system. Again, we're doing that on a service-by-service, pathway-by-pathway redesign. We're at early stage of development with primary care. We've met with both local medical committees, and specifically to address issues that, just as we want to assure members of the public, this isn't about cutting services. It's also not about inappropriately shifting work from one part of the system into another part of the system. So we're working together in partnership. We're particularly exploring some vascular pathways of care at the moment, which we're hoping to be able to take forward, and also around some of our cardiology pathways.
Yes, it's just on following up on that issue, really. We're talking about increased information flows here. With patient-initiated follow-up, there'll be stuff coming from the patient to the clinician, and likewise on test results, there'll be stuff coming from the clinician to the patient. It's quite difficult accessing GP services over the phone. People may not be able to actually travel there. You talked about a specific system which is not Skype, but which is secure for having video conferencing effectively. What about the use of text and email to inform for patients to be able to inform the clinician and vice versa? Now, I know the old response to this was it can't be done because it's not secure. So 2 things, can it be secure? And secondly, if the patient gives their consent for the information to be shared over an ordinary email system, why can't that be done? Thanks.
Some of the overwhelming feedback through the Health Watch survey was, can we have the use of email, text to inform us of the test results? We have launched something called the Patient Portal, and that's now being rolled out across the systems. It's being rolled out across the NHS, and this is where patients can access their information I could sit here with my mobile phone, log in my NHS number if I've got access to my patient portal, and I can see my test results. What we're looking at the moment is how we can expand that to build in email, the use of email, the use of text, and how we can better communicate with people rather than sending them a letter or doing it via the GPs. Absolutely take on board what you're saying there. And vice versa. Yeah. We would like to progress it to that. At the moment, the technology doesn't let us do it vice versa, but we will take that on board, and we would definitely something that we would like to progress.
Sorry, can I just ask a question on the test results? I know from experience, my own experience, that I had a few tests. I went to the doctors for the results, and the receptionist said, "Well, I can't actually give you the tests over the counter because you might need to sit down. So you need to go and see a nurse for the results." So So if somebody has some test results and they're not good, I mean, mine was just a fine thing in the end. But if the test results, you know, is something that may shock the person, how are you going to deal with that?
Test results that may shock someone would need some follow-up care. We therefore wouldn't be doing that. We wouldn't be looking to do that via text or via email. That would be on some form of, depending on the test results, it's hard to say because it's not one size fits all. It may be something that could be done over the telephone in a conversation, or it would be face-to-face, without doubt.
Moving on to the consultation and engagement then, Facility, you had a question.
Can I just ask you in terms of timescales and when are you wanting to go out? And obviously, I know we've had you here a couple of times and sort of talking about this, but I'd like to see the results of the consultation as well and give us an opportunity to talk about the results that you find from the consultation that you've done.
Okay. So in terms of what we've been doing, we've been meeting with a range of services from within the hospital and with primary care colleagues to look where there's opportunity for change. And just in the report and the slide, I think the result of that is that it's identified a range of opportunities. In each of those areas, we are working with those colleagues and putting in place or accessing existing service user groups to see, do these ideas, can we take them forward? Can we implement them? So I don't have a document that says we've undertaken an engagement and these are all the findings. We obviously have the engagement that Health Watch undertook around general public views. We've been doing this since the beginning of this financial year, and we've generated a lot of interest from clinical colleagues. Now, I'll take an example to bring one to life on here, and I can't remember what it'll be called, whether it's orthopaedic clinics or fracture clinics. We currently have patients who have a fracture, break a bone, come to the accident and emergency department. The majority of them will be asked to come back to a follow-up clinic adjacent to the accident and emergency department to see a colleague within the orthopaedic services. That means that's a very high volume of patients attending clinics. And what we're looking at is a redesign there, which could mean that some patients don't need to come back at all, because actually there's some fractures where, with support into A&E, it's very clear with advice provided to patients they don't need to be seen. There are some patients where they don't need to be seen, but they do need an orthopaedic specialist potentially to review their x-rays and then to be able to discharge them, and they can do that without the patient having to travel to hospital for that, and then have a phone call to tell them everything's okay. And then there's a proportion that actually do need to be seen. And that's the proportion where we'll continue to offer face-to-face. As a result of that, we think only a third, potentially, of the people who currently come to those clinics actually need to attend. For those patients, they'll have a shorter waiting time in clinic, a better experience. We'll also be able to guarantee that they see the orthopaedic specialists from the right subspecialty area, which will be a benefit, because sometimes now the high volume means that's not always perfectly matched on the day that they come. So by looking at that redesign and that re-engagement, all of that pathway is being mapped out. And what we did specifically is engage with a service user group, and that involved also working with patients attending the clinic and seeking their views. And that was undertaken by some of our lead clinic nurses on the day, capturing their views to make sure that what on paper looked like a sensible redesign, what the views of people were. And again, overwhelmingly, people welcomed that they wouldn't have to come if they didn't need to come to clinic for those appointments.
Just be clear then about this. So you've done some clinical engagement. You've got the Health Watch survey that was around general principles. You've done some clinical engagement, and are you engaging with the service users of those services where you've got years 1 and 2 where you want to change? You're going to engage with the service users of those services to see whether your proposed redesign actually will work for the patient. And so what are your timescales in all of that? Can you...
So our timescale, we're currently within the slide set, the schemes that we're implementing, which is a smaller subset, we're implementing in year. Some of those have already started, such as the urology clinics. There's a number of other examples. The other ones have dates, I don't have them in front of me, that are within the next few months to be implemented. In terms of this back page, we'd like to explore all of these as quickly as we can. Our constraint on that is obviously supporting colleagues, enough capacity. Our intent is to explore every one of these opportunities as quickly as we can across the trust. So again, I haven't got a definitive, we're going to get so many done by the end of this year. We're working very much on an engagement process of where there's appetite for change and where that's better for patients and where we can deliver it. We want to progress that. We have had the benefit as well of some interest recently from NHS England and our clinical commissioners and some external support into that capacity.
Yes, then, is there a CCG decision process in all of this? Because this involves primary care as well. So where is the CCG decision process in this?
Maybe a question for the clinical commissioners, but this is a scheme which is absolutely fully supported by both clinical commissioners, and in fact the accountable officer for Calderdale is the lead at the Yorkshire and Humber, the West Yorkshire integrated care system for leading this programme of work. So there's very much full support from the clinical commissioners and their engagement. They are members of the partnership group. Where we're redesigning services within our existing resources to deliver better benefit for patients, we're implementing those as part of our normal way of, improving services and delivering care. If there was a change that it was felt that it needed to be escalated into a more formal decision-making process, the involvement of the two clinical commissioners in the heart of this project means that that would happen on a service-by-service basis.
Yeah, just on the governance of the programme, I noticed you've got representation from Healthwatch. Did you consider having direct representation from patient groups on the governance board?
Yes, we did, and we think patient representation is really important. The governance board is a governance board, so it's overseeing a programme of work and the delivery against these schemes. So it isn't the forum where there's necessarily the level of detail related to wanting to spend time with service users to really understand their current experience and how that can be improved. We've designed it so that for each of the service areas that more detailed engagement will happen. Also mindful that it's one service user, two service users, they're not representative of this broader range of services, their experiences. We've just talked about trying to design this specific to the needs of individual cohorts of patients or people. And we saw that it would be difficult to say that by having a number of service users on the group, you would satisfy that. So we're placing significant importance that every service that we change, there's detailed service user engagement, Healthwatch representation on our group, members of our Council of Governors, we haven't said that's the forum for patient engagement.
I'm finding it quite difficult, so the governance part is not where the patients are, because obviously there will be so many different medical, whether it's respiratory or whether anything else, so there won't be anything. You've used Healthwatch's public consultation to be able to help you assist to get what you need, but it doesn't, and I'm sorry if it's not the same with the whole panel, it doesn't reassure me to say that each particular, whether it's in year 1, year 2, when you're asking for respiratory or whether it's trauma or anything, or cardiology, it doesn't tell me that you actually have engaged with them in particular. I can understand that you've done the whole, broad range of investigation and a consultation, but it doesn't actually give me confidence to say that you've actually looked and spoken to those particular patients with those kind of illnesses and issues, and you get their feedback from them before this is implemented. And obviously we want this to happen, and the whole reason that, like you say, it's not about the cuts and everything else like this, but surely in that case, and those patients or those people with those illnesses should be the forefront of making any other decisions, so that not having those people, having those responses back from those people is definitely a miss.
I understand the concern that you're raising, and I think the way that we assure ourselves through the governance board is I spoke about every scheme that we would implement will be subject to a full quality impact assessment, and one of those tests of that quality impact assessment would be the demonstration of service user engagement, the views of service users, the feedback from those service users, and including the equality impact assessment. So the governance body would need to be assured that that had been undertaken. But those meetings of the governance body don't do all the detailed work of the programme. They have oversight of the work of the programme. Is there a suggestion of what you would like to see on that body?
Patient's voice, in some form, basically. And I can appreciate you can't do the whole collective version of it, but whether it's a forum's voice that you can bring through, that would have definitely been there. I just find it very, very difficult to say that you speak about today implementation of this scheme, going through an implementation of schemes for the future years, and definitely the patient's voice has somewhere in between all the governance and everything that's happening has just withered away because you just feel that it's not there.
I obviously take that very seriously and want to respond. I do think we've built into the way that we're working the importance, and if that's not giving you assurance today what you've seen, then we need to do something to remedy that. Through Health Watch, we've sought to ensure that representation on that body, but obviously take your comments, thank you. And I don't know, Lisa, if there's anything you wanted to add to that.
We've also had conversations with Health Watch around some of the long-term conditions where we have established groups, so diabetes, COPD, rheumatology, pain. There are established groups, and how Health Watch can facilitate the communication and engagement with those groups to make sure that our direction of travel for transforming those services is in line with patients' views, and that's taken on board and built in, and we are and then how we can then constantly go back and check out that we're doing the right thing. So we are having those conversations with Health Watch around how we can better engage with those groups. The services that we have implemented so far, we have engaged with the patients, the users of those services, to take their views on board, and we've done evaluations with them to say, how is your experience now? But for the larger scale ones where there are established groups, we will be looking to use those groups.
Can I just check, because you mentioned, I think, was it orthopaedics that you mentioned, or was it fractures? I think maybe fractures. That you said you'd engaged with people who'd been in the clinic on that day. So have you done more than one day engagement? Have you just asked people on a specific day who were there, or have you made sure that you've got a wide range of service users that have been asked? So younger, the more elderly and elderly service users, and the ones in between. So your equality and diversity have been fully taken into account in your discussions with service users.
We have undertaken the interaction with clinic users. We've taken an equality impact assessment. I think that the point that you're raising is that you're asking that we ensure that service user engagement that we undertake, we particularly target the subsection of representation, and we'll take that away with us. That's very helpful, Liz. Thank you.
Because some people may be more willing to be involved, and some people may be far more cautious about this, and particularly vulnerable people as well. So I think you need to hear as a wide range of voices in this whole system. Okay, are there any more questions that we've got? So I think we need to understand better the capacity in primary care as well, so that when you're moving this scheme into place, that the capacity is there in the primary care system. I think probably we need more reassurance on that as well, and we realise that will be from the CCGs that we need to get that. And also some more information about the demand and capacity across the system going forward, not just to 2020, but how this is going to help you in the future as well. We've talked about the impact on vulnerable people being taken into account, and I think would we want to better understand the engagement process? Have some more examples as to how, service by service, you're going to do this. I think we need to understand that better. Yes? Yeah. You say there's no sort of the CCG's decision-making process. They fully support, and if there's changes in services, it will be service by service. I think we need to understand the CCG's decision-making process in all of this as well. And some clearer timescales. The offer to see the technology in the patient portal, would we like to see how that works? Yes, I think that would be helpful if we could see how that works. You've answered about the security, but also the outcomes. How are you going to ensure that all of this, people, at the end of the day, there's better outcomes for people? I think we need to understand a bit more around that as well, don't we? Has there anything else that I've missed? No? Also, across Kirklees, obviously you're just talking about a part of Kirklees, and we look at across Kirklees, and there are people that have outpatients appointments within your trust from elsewhere in Kirklees as well. And I'm wondering if more conversations with Mid-Yorkshire around this and how the demand for outpatient appointments as well across Kirklees is better managed. I think that would be useful. Certainly I think more joined up work with Mid-Yorkshire would actually provide better outcomes for people across Kirklees. Is there anything else that we've missed? No, we've got everything. All right, okay. So Richard will talk to you about how we get that back to the committee and everything. All right, okay. But I think what we're saying is there are some pluses in this. Yes, we can see some advantages to people. We just wanted to know more about how it works and your decision process and your engagement, and making sure that people are comfortable with the way forward. All right, but we can definitely see that there are some benefits to people in this.
I just wondered and suggesting if we're going to arrange potentially for those of you who wish to perhaps a visit to see the technology, we could also maybe arrange for you to see some of the service examples, maybe meet some of the clinical colleagues, maybe some of the potentially some of the service users as well, and that might bring a greater richness as well to some of what we're doing.
Okay, thank you very much for coming today. Okay, thank you. All right, okay. So next on our agenda. Okay then, we'll resume then with the Kirklees Integrated Wellness Model update. The wellness model has been to the panel a couple of times, and this is the way forward that is being described to us, and we need to consider the information and determine if we need any further information or action. Okay, so are you going to introduce yourselves and do you want to introduce your report? Bearing in mind that we will have read it and we will have plenty of questions.
I would assume nothing less. So I'm not going to talk very much about the wellness model because this is Carl and Jill's area of work. But I'm Emily Parry-Harris. I'm a consultant in public health and I'm head of public health at Kirklees Council.
Hello, my name's Carl Mackey. I'm Public Health Manager at Kirklees Council.
Hello, Jill Greenfield, Head of Local Integrated Partnerships, Kirklees Council.
So, as you say, Councillor Smage, hopefully the paper kind of addresses some of the queries that were raised in your conversation with Emily. And obviously, if colleagues have read the paper already, we're happy to take questions and queries and provide more detail where necessary.
So, your integrated wellness model is described in the blue slide papers that are here. We'll open it up to questions then, Dave.
Yeah, can I just clarify first of all that, because it says the rationale for not going to market, and it says that you're not going to market, you're going to keep the service in-house, and then, but you have gone to market, but that's for an external partner to kind of advise and put forward ideas about how the service might be delivered in practice. That's just a clarification. And what you said is that you have selected a partner, Big Life. Could you say a bit about Big Life?
Yes, Big Life are a relatively small organisation based in Manchester, and they have experience of delivering and implementing integrated wellness models in other areas. Two examples include Rochdale and Salford. We've been engaging with Big Life right from the outset amongst a whole range of different potential providers when we first started doing the initial market engagements. And we've had quite a few meetings with Big Life over that period. And one thing that we've been struck by is their values, their approach, the experiences and insights that they bring from delivering models elsewhere really chimed with our vision for our wellness model. And as the report highlights, we basically produced a bit of a brief to go out to market, to bring in a partner. And each provider submitted a proposal, and their proposal was the one that we were most impressed with and met our requirements to the standard we wanted.
And are they a not-for-profit organisation?
They're not a non-for-profit organisation as such, but they are the values of the organisation are rooted in that philosophy. So they're not technically a non-for-profit. I mean, I give you an example of some of the other things that they deliver. So the big issue, for example, is something that they're involved in as part of a kind of bigger umbrella of organisations, and they deliver services and interventions around employment and that type of thing. But they're not. They're not a massive organisation in terms of providing, acute healthcare provision and community healthcare provision. As I said, they're rooted in small-scale provision and integrated wellness models, that type of service.
So you talk about bringing some services together, what you currently have, perhaps with GP services and pharmacies and stuff. Can you give us an idea of what kind of timescales the referral would work in and how the referral system will work itself? For example, in terms of obesity, just by reading up an information mention with stop smoking clinics, you get referred in and through your general practitioner service, and they go to a clinic. They go through like a 4-week course, and then it's a basic cycle that keeps them going. Unfortunately, sometimes round. I just need to get some kind of an idea of what's going to change and how what's going to be better for the patients themselves.
We want to improve that kind of pathway into support and provision. As you've quite rightly pointed out, there are pathways at the moment, so mainly coming through the GP, certainly in terms of stop smoking support and help. But we actually commission GP practices to deliver stop smoking, so it's not really referral as such at the moment. It's within their kind of their own provision. But in terms of our offer of stop smoking support, as well as health advice and interventions around other health behaviours and health improvement activity, we want that process of referral, engaging in the service to be as seamless as possible and as quickly as possible. One of the things that we've emphasised in previous papers to Scrutiny panel is part of the rationale of designing the wellness model was about addressing some of the inequities in access at the moment. So we know, for example, a lot of groups of people with a high risk of long-term conditions or long-term conditions, don't access provision in primary care. So those referral routes we can't rely on if we're going to address some of the inequities, and that's where we're working with colleagues like Jill and how we embed wellness within Community Plus, which I'll let Jill come on to in a moment, of how we kind of work that up and make that much more seamless. So I can't answer your question perfectly this moment because we're still working that through, and we'll work it through with Jill and the partner. But that is certainly our aim, is to make sure there's ease of access and we get to those at high risk and more vulnerable who aren't engaged in the typical referral routes coming through primary care.
Just to add on what Carl has said, we're still working through that model, and we're trying to use a co-production approach to that, so that we're working with people. We hope to be working with the people that it will affect. But in terms of the approaches that we're hoping will be embedded, is that where people are at, they will be able to access, whether that's through the places they already go in communities, through being able to engage with a number of services that aren't always the GP or the more medicalised services, because that doesn't always really fit everybody's motivation to change. And some of this is about our concern about those people who aren't coming to the front door of the GP, and how can we create those opportunities for them to engage with maybe another activity that then leads to actually developing that motivation to stop smoking, whether that's to be able to spend more activity time with kids, or whether that's around something else that's happening in their lives. And it's just where we can get those hooks for change where people are already at, rather than a formal pathway all the time. That is important for some people, but it's about where else and what else would work for other people in communities.
Yes, in the timescales you mentioned that there'll be internal staff transfers to Communities Plus by next month. Just to clarify, is that the health trainers, the expert patient programme and the Active for Life staff that'll transfer to Communities Plus?
Yes, they'll transfer to my management from their existing management structures, and as part of that, and this is key for the development partner, that we can ensure safe everyday practice of what is already in place, as well as alongside develop the new model and work hopefully seamlessly to make sure that we get those on a parallel journey that at some point come together. So that is on track to happen. Health trainers, we're taking a little bit earlier them pals, and we're in the process of those handover conversations, and they've all been set up with the current head of services. And prior to that, we have been meeting with the management team of those services for the last 3 months now on a regular basis, because we're trying to support their process through the transition and involve them in the development of the new service as much as possible as well.
And you mentioned you were head of local integrated partnerships. Could you just give, just briefly, what role, what is your role? Thank you.
Yes, I think that's best described as around taking a lead on our community-based approaches to a new focus for the local authority, newish focus, around how can we move services further upstream around early intervention and prevention to where people are at, using more sustainable community approaches to delivering that help either earlier, before problems arise, but also where people are already experiencing crisis. So, for instance, at hospital discharge, what can we do that's not formally service that stops people going back into systems as well? So there's a raft of kind of services development there that is a bit of a hybrid of community development, but also really trying to look at our work under what will reduce, prevent or delay access to formal services, and using the assets and strengths of communities and peoples themselves that are already there to enable us to do that.
Can we ask around community-based approaches, because your paper says that the requirement is for your external partner to design community-based approaches to wellness. Now that sounds a bit as if you're going to have new community projects instead of actually using community projects that are already in place. So how is that design of community-based approaches, how are you looking at what you expect from that, and how are you going to involve community services that are there now in that design?
Sure, it's a difficult task for sure, but I think the first premise of what we try to do there is build on strengths that are already there in communities. So in terms of a community-based approach, an example maybe from our Community Plus work is that instead of, so we may be in an area where there is a number of individuals saying they want more access to luncheon clubs and carer support. So we don't create a new provision, but what we have done is talk to existing provision and link them in terms of sharing their own assets in terms of venue costs, applying for funding, etc. So instead of providing 2 sessions independently across a week, they may be able to provide 4 sessions with extra support around accessing other funding, sharing costs, sharing strengths. In terms of the wellness model, what we are hoping to do, and what we certainly are planning to do, is to engage with our full range of stakeholders. That is part of mapping the existing provision, because that is a really important part of the vision that we have around integrated wellness for Kirklees. And there is a strategic group that also brings some of those providers together, as well as doing that on the ground around engagement and engaging with individuals throughout the development of the service about what works, what isn't so working so well, but importantly within that as well, capturing those system challenges, because sometimes it can be about where services are delivered and how they're delivered that we need to feed back as well from the work that we're doing. So our development partner alongside with us is already developing a list of people that we need to engage with, from ward members to individuals in communities to existing services, which is really building on the work that has already happened over the last, 12 months more around the wellness, and we'll develop that into a clear plan of engagement. But that is co-production is really clear for us in achieving that outcome.
Can we ask then, you say you're talking to ward members. I don't remember seeing anything about this as a ward member. No, none of us do. And Community Plus, I know they've been doing some mapping of services as part of their remit, but they're not really talking to elected members either. So can we ask that when you're doing the mapping, because every time there's a new scheme or there's a new project or whatever, the first thing is about mapping services. And if you're using data that is already there, that is already not all of the services that are provided in an area, then you're just compounding the problem in that you're using, I won't say it's incorrect, but it's not as full as it could be. And therefore, I think there needs to be far better engagement with actually community projects who may say, oh, what have you spoken to? As well as ward members as well. Far better than it is currently there. Okay, but Lynn, you wanted to come in on this?
Yes, thank you. Focusing on partnership working and co-production, have you explored with the Mental Health Trust's Recovery College the scope for extending their focus beyond the remit of mental health to encompass physical health too, to have a joined-up holistic approach to well-being?
Yes, we have, to answer your question. We've been engaging with the Recovery College provided by Swift quite extensively over the last 12 months. And we're both in agreement that we need to look at how we share resources to maximise outcomes around both physical and mental health. So that's very much what we're looking to do. The detail behind that and how we can connect the wellness with specific provisions within the Recovery College, again, that will come to fruition, I think, as we start to progress and work more closely with partners like the Recovery College. But we've certainly had, preliminary conversations, and we're all on the same page of the need to do that, essentially.
Because quite often at the Recovery College, partners will come in and co-deliver presentations, and I think that's a real opportunity, because the Recovery College is building on its expertise and what it can deliver on an ongoing basis. So I would certainly encourage that continues to be explored and that we maximise on those opportunities.
Yeah. Just the final point for your reassurance as well. We were so impressed with the work that the Recovery College do that we actually invited a service user, one of their service users, to come and present his experience at our initial market provider events to really get across this is the way of working that we want, and this is what we mean by that truly person-centred, holistic approach.
Thank you. That's reassuring to know. And I think we all accept that physical health and mental health well-being go hand in glove. And a lot of the volunteers at the Recovery College are peer mentors and role models, basically. And again, the importance of volunteers supporting people on a one-to-one and ongoing basis shouldn't be overlooked either.
Can we ask your range of partners that you've got, providers already working on things, page 20 of the papers, there's a list, and one of them is NHS health checks that are currently delivered within your GP practice. Now, the next paper that's on diabetes, there's quite a bit on there, and the problems in take-up of those NHS health checks. So how are you looking to be able to provide services such as health checks in the future to be able to look to better take up in areas where there is a need for the take up but where there's a shortfall at this moment in time?
Absolutely, that's at the heart of what we're trying to do with the model. So we envisage that all wellness workers employed as part of the service will be trained up to be able to deliver health checks. The issue that we have at the moment is we have significant inequities of access for health checks, and that's primarily because we only have one referral route and one way of delivering that, and that's through primary care. We've got a clear, what we call social gradient to health checks, so people from the least deprived communities don't access the offer. So by training up wellness workers to be able to deliver health checks in a whole range of different settings out in the communities, doing it opportunistically, doing it in a way that is focused around building relationships with people, with groups in communities, and then we could pull a wellness worker in where that relationship's established and deliver health checks that way. And this is all based on evidence from other areas that are adopting this approach as well. We call it the mixed model. So it still maintains some provision within primary care, but there's also opportunities in the community to deliver health checks through other workers as well. You don't necessarily need to be a clinician to deliver health checks.
Sorry, could you just expand on that a bit? Just in terms of what type of health checks can be delivered by people who aren't clinicians?
Yeah, so the examples in other areas, as part of the NHS Health Checks Commission, they operate models whereby community workers, physical activity development staff, wellness workers, those type of roles in other areas, who maybe deliver health and wellbeing interventions, but they can be skilled up to be able to deliver the health checks in exactly the same way as, say, a healthcare assistant or a practice nurse would deliver in a GP practice. And it involves things like blood pressure testing. We can implement what we call point of care testing, which sounds a bit extreme, but it's essentially finger prick testing of blood on the finger, and you can then detect cholesterol levels and things like that pretty instantaneously. And this approach is happening quite extensively in other areas. It's not that radical really. So we want to kind of build on that approach, but obviously as part of training staff up to do that, we want to ensure that there is governance around that, there is quality, staff are trained up to a high level. So we will have to bring in that, whatever clinical governance is needed around that, but we're learning from the other areas and looking at how we implement what they've done successfully.
Sorry, just to follow up. So from the individual's point of view, they'd need to have some confidence that it was a non-clinician who was carrying out these tests and that they had been properly trained, and particularly on issues like confidentiality. Is that sort of part of the package?
Absolutely. And that will be led by the staff themselves to some extent, when they feel confident. As you rightly point out, some staff will be more comfortable about doing certain things and talking about certain things than others. And it's part of that ongoing process of training staff up. It's one of the reasons why the whole model will be a phased approach, because we thoroughly appreciate that a lot of staff development and training will need to be implemented, and a lot of that comes with experience and confidence, as you point out, not just formal training. So staff need time to develop and need to be supported as well.
Having been present when checks have been carried out in the community by non-clinicians, I've observed the anxiety and the follow-up questions that arise when those checks don't get an all-clear outcome, and people can get very distressed very quickly, and it's what urgent follow-up is in place for that person when a check that's been carried out indicates a need for further investigation.
Absolutely, and we need to make sure that staff who are delivering those checks are confident and be able to work in a way that provides that reassurance and addresses that anxiety. And there may be a little bit of hand-holding on behalf of that person who's working with that individual, you know, to kind of provide that reassurance, explain things in context, but really rooted in that person-centred approach. So, again, as you touched on previously around the links with mental and emotional well-being, you know, it's delivering health checks in context of where that person's at. So, and what are priorities? What are priorities for that individual, not necessarily the person who's doing the health check, and putting things into perspective and into context. So having high blood pressure is something we might want to address, but, you know, it's somebody could interpret that as, you know, that, you know, get really panicky about that and I need to address that. So it's having somebody, a worker who's skilled to be able to mediate that and provide that reassurance and put things in perspective and always have the person at the heart of what it is they're doing. Because we can find solutions to other things and get access to other things. But if somebody leaves an interaction with a wellness worker where they're highly anxious and worried and concerned, then that intervention hasn't worked at all, and that's absolutely what we want to avoid.
I think that is really important, because if I were with my GP, for example, and it was established I had an irregular heartbeat, my GP would then be able to tell me exactly what would happen next and perhaps give me some indication of timescales. But if I'm with a non-clinician person in a community environment and I find out I've got an irregular heartbeat, at what point am I going to get to see my doctor, and what's going to go through my head in the meantime? So I really want to stress the importance of thinking carefully about the types of tests that are carried out and who is carrying them out, and indeed where and when as well.
I think it's worth emphasising that there will be protocols in place that indicate when clinical help should be sought. So if there was something that was brought to a non-clinician's attention, there'd be very clear boundaries set out as to what they can and can't deal with and pathways into care. So if somebody was found to have, you know, clinically dangerously high blood pressure, there'd be a response or a heart rate that was, you know, clinically concerning. That route would be established. So it's really important that the people who are undertaking the health checks as non-clinicians have really clear boundaries around what they can and can't be part of, and that's part of the reassurance, I think, to the population as well.
Thank you.
On page 23 of your document, you've got a whole list of what you want to achieve. And you talk about specialist resource targeted at the right people at the right time. And then it's supports an intelligence embedded and driven approach to service development, shared communication and data systems. And then you've got transformational relationships between individuals, communities and systems. So that's what you wanted to achieve. But how do you think you want to do that? And how are you going to measure that you've achieved all of those? Because there's a lot of words there that don't mean a lot to quite a few people, but actually being well and avoiding being ill is very important. So how are you going to make those changes and be able to achieve that, and how are you measuring that achievement?
That is part of the development work that we need to do over this period, and I think the most important is the building blocks of how do we get people to report that they feel well, against also some of the indicators that they may not be. And that's around our outcome framework that we need to develop, which the way that we are wanting to approach that is by working with people, using expertise from our development partners, what has worked elsewhere, about what are the measures that would say that this service has had a positive impact on people in Kirklees. So it would be working out what are the measures around wellness and developing our own recording and measure of that, so people know at the front line that they're actually having an impact, and that is reported to us by the people we're working with, not just a practitioner saying, yes, it was really great because Mrs. X is now reportedly feeling better, but that they are also self-reporting that, and that where needed, that would be triangulated with any clinical interventions that's needed if it is at a higher level. So, and I get there are a lot of words there around co-delivery and co-production, and I think the starting point for all of that is about listening to what there is already, really starting where people are at, but also using what we know about areas, which I think has been touched on. So what do we know are the issues facing populations in Kirklees already, in communities that we know about? What do we know that would work in communities? And really engaging to find out what is it that people would say would have improved their well-being, and really working those into some measures that are meaningful and do describe impact that as people experience them, not just as a report that can show quite a few nice graphs and all the rest of it.
And how are you discussing with clinical commissioners as well, how this will impact our to help with the hospital avoidance and making sure that people stay well for longer? How are you making those links into that clinical commissioning arena?
It's really interesting to see Anna as she was leaving. I'd like to have been a fly on the wall for that conversation. I think that's somewhere where we really need to make progress next. One of the challenges of wellness is that we're going to, by putting interventions in place to improve people's health and well-being, we will be preventing things from happening, and it's a real challenge to measure something that hasn't happened. So there's a challenge around that. I think there is a more robust conversation that needs to be happening around hospital avoidance. And we've made some real progress, as we were talking about yesterday, Councillor Smage, with the CCGs, really shifting their thinking around hospital avoidance and prevention. I think 6 months ago, hospital avoidance was about turning ambulances around in car parks and sending somebody somewhere else to receive a service. I think we've now got a much more robust conversation happening about the need for prevention that is much further in advance of that. The CCGs are engaged around wellness, and I think it would be fair to say that initially they were quite suspicious of the wellness model and weren't particularly well engaged, and viewed it very much as a kind of, well, if the GPs aren't going to be delivering it, we don't trust the model because we're the doctors and we know. We've worked quite hard with them over the last 12 months to try and move them away from that. We're the doctors and we know. And we've got lots of evidence that shows that actually only about 10% of somebody's health outcomes are anything to do with whether or not they've seen a doctor. So we've had a real shift in that thinking. But to answer your question around linking it to the hospital avoidance, I think we're at the start of that.
Because there's an ever-increasing number of people likely to have long-term conditions, have diabetes, have mobility problems, and be overweight, obese. So it's how to turn those inequalities around for people. So,
yeah, absolutely. And really interestingly, the health report for England was published. I think it was published a minute past midnight last night. So I've spent a little bit of time reading it, but I haven't spent a huge amount of time reading it yet. But what that is telling us is that people are living longer. And I think always, whenever you say that, you need to remind yourself that that's a good thing. And we talk about an ageing population sometimes as though it's a bad thing. So it's a good thing that people are living longer. But what the data is showing is that people are experiencing ill health for more of their lives. So if you're going to live to 90 and live a sixth of your life in poor health, that's a longer period of time. So there's all sorts of challenges around that. The wellness model will support people to undertake behaviour and lifestyle change, but there's also the broader public health agenda around that real primary prevention. So not to tell you the things that I'm going to tell you with the diabetes paper, but the work that we're doing with schools and with families and with maternity services to really start with that best start in life, so that actually in 20, 30, 40 years' time we have a population that don't require behaviour change interventions because they've lived their lives in a different way.
Any other questions from anybody?
Just looking at publicity, I'm wondering if you've thought about wider publicity highlighting about the value of health checks. This means you, this applies to your approach, because otherwise certain people won't even reach the stage of engaging with whatever is put in place. And we've had the Be Clear on Cancer type adverts, which I personally find really effective. And so I'm just wondering, what thoughts you've given to actually publicising on a wider scale the availability of early intervention health checks, please.
Yes, that's going to be absolutely key, as is publicising and promoting the wellness model as a whole and what's on offer. And that's very much something that we've articulated in the specification, so then we can work closely with Jill when we do launch this thing. A lot of promotion and targeted promotion is going to be needed through campaigns, through word of mouth, through links into communities. But specifically around the health checks, we do get a lot of national campaigns and resources fed to us from our colleagues at Public Health England. The Be Clear in Cancer is a good example of that. And at the moment, anything that tends to come through, we will filter through to our comms colleagues and comms colleagues at the CCG. But I think, for me, when the model goes live, there's something about how we do some very targeted, specific promotion around health checks in a way that is engaging, because I take your point around your experience around the Be Clear campaign and the effectiveness of that. But evidence does show that the campaigns as a whole don't really address some of the inequities, the entrenched inequities that are out there in terms of access. It's about working with people on a one-to-one basis and holistically and building relationships, getting that trust, resolving other issues, and then using that as a way in to provide things like health checks. So it's having that approach balanced with the campaigns as well, as you've touched on.
I think the difficulty, of course, with the one-to-one approach are resources to enable that to actually happen in practical terms. Yeah. But thank you for that.
Can we just quickly ask about engagement then? Because you're saying you're doing some engagement in September. We're now in September. So what are your plans for engagement? You're going to deliver engagement events and activities. So what are you planning to do there? Where are you going to do them? Etc.
I think we're at the beginning of that journey, because we are still designing the model, and part of that will be with the key stakeholders that we've already engaged with as part of the Wellness Recovery College, the other providers, and then building on from that. From gathering some of that information, is working with our development partner about actually a full engagement plan, which will include members, it will include community members, and it will include our you know, the providers that are, whether that's community-based or larger providers, but we've got to get a frame for that to make sure we get it right. I have heard some of the, you know, the messages about ensuring that we're not ignoring what is there already, how important ward members can be with telling us what's current, and it's about actually pulling that plan together that will be really comprehensive, and to do it in a planned way, because there are a lot of stakeholders involved here, from GPs, CCGs, to actually people who already are receiving a service. And one of our main priorities has been that those people already receiving services aren't worried unnecessarily with, we're developing a model and this may stop. And actually, when we get to that point, that we're telling them what is going to happen, so there is less uncertainty in what messages they hear.
Can I be right to assume that you'll be bringing the outline of the engagement plan back to us to be able to have a look at, just to make sure that we've covered all angles?
Welcome that feedback. That'd be really helpful. Thank you.
Yeah. I think we would like to be assured that all areas of Kirklees are covered by your engagement plan that we feel need the engagement. Right, okay. No, any more questions? No, right. So, we would like to see your engagement plan. We would like to understand as well what publicity you're going to develop as you move forward. I think, are we looking to see what the model is as it progresses? Do we want to look to see what the model is, the way it is going? So maybe we need some progress updates on this, and Richard will discuss how we can best do that. Also, the mental health and physical health. So we need to ensure there's focus on both, please. That there is connections between that wellness and primary care. So I think we would need to be assured that that was happening, definitely. And you were saying that you're going to put protocols in place, so we need to understand that what that is in the model as those are developing. All right. And I think on the hospital avoidance, this is a far bigger conversation that we as Scrutiny need to have in the whole system, as how to look, how the system is looking at helping people to stay well for longer and avoid the need for going into hospital and those long-term conditions as well. So there needs to be a far wider conversation, I think, on that as well. All right. Yeah. So have I covered all the points that everybody feels we've addressed? Thank you very much indeed. We will now move to the diabetes report. I take it that you are for this report as well, Emily? Yes?
I'm a lucky girl.
We have, it is a public health report. Perhaps you could introduce it, and perhaps you could outline where the CCG... Or the colleagues outside? No, it's just yourself. So maybe we could outline as well where the CCG is in all of this as well, please.
So I'm going to work on the assumption that you've read the report. Just before I start with the overview, there's a word missing. There's a really important word missing on the top of, in your pack, page 31. The third row down, it says this can be attributed to the higher prevalence. It shouldn't. It should say that this can be partly attributed. It's not the whole story, and it's really important that that word's in there. So, when you've proofread something so many times, you stop seeing the words. But I just wanted to pick that up before I started anything else. As Councillor Smage outlines, this is a public health report, and our role in diabetes is around the prevention of diabetes, and so therefore the vast majority of our work is around type 2. There is very little in this report around the treatment pathways for people with diabetes, and I acknowledge that as a gap. If you wanted more detail, at another point we could do something with our CCG colleagues. It just happened that the request for the report fell at a time when it was difficult to do that in terms of my annual leave and then colleagues' annual leave. So this is a public health prevention type 2 focused report. You've got a section of narrative that takes you through the story of diabetes in Kirklees, and then you've got a section at the back for the data as well. I hoped that by doing that it meant that you could read the story and then look at the data alongside it rather than having to navigate both. I think as a high-level summary of diabetes in Kirklees, I'd say there's a lot of it about. In technical terms. We do have a slightly higher prevalence of diabetes in Kirklees than the England average. Part of that is explained by our higher South Asian population in North Kirklees because of the higher propensity for diabetes, but it doesn't explain all of it. We've talked before in this panel about higher prevalence of obesity, which again answers some of the question as to why we have a higher level of diabetes. I think the work that Carl and Jill have outlined around the wellness service is part of how we respond to that. There's also significant roles for public health around that wider factors work, so working with our planning colleagues so that when applications for food premises come in, we as a local authority have a response to that to try and reduce the number of fast food outlets. There's a very, very clear correlation between poverty, high levels of deprivation, high levels of obesity and easier access to fast food takeaways. So it's not rocket science that we need to create the environments in which people live their healthy lives. Public health historically was a bit finger waggy, and we could be a bit, you shouldn't do that, it's bad for you. So we would talk about spoiling people's fun one intervention at a time. We tell you that you can't smoke, we tell you that you can't drink, we tell you you need to do more exercise. And actually trying to move public health and the wellness model into playing our part in creating the place in which people live their best lives. So it being less about treatment and more about creating that whole environment. In that context, the report is offered to scrutiny.
Do we have any questions around this report then?
I'll quickly get this on in and do apologise for the interview as well. So on 2.1, obviously, I need to refer to the report as well about the low uptake within the South Asian communities about the effects of diabetes and obviously the plan we are trying to offer. What can we best do to make that change now? Because, I mean, obviously, on page 43, you've got a list of obviously the surgeries and where the referrals have come from. Yeah. It certainly doesn't marry up with the number of reports that have come through. What can we work with? What do you think the reason is, basically?
I don't think there is a single reason. I think there's a whole range of reasons. There's language issues, there's barriers to accessing services, there's I don't want to use the word apathy, but there's a sense in some communities that this is an inevitable part of ageing. Well, it's not. It's something that's eminently preventable. So I think it's a really complex picture that we are trying to deal with. I don't think the medical model is the model that is going to fix it, because it's not about a doctor telling you need to lose weight. It's about living a healthier lifestyle. If we achieved health improvement by telling people to do things, I'd be a size 10 and I'd drink less gin. So we know that doesn't work. So it's about having that broader contextual conversation. I think the community-based projects are absolutely key to this. I think raising people's expectations, increasing the way people value their health, and therefore they're more likely to engage with health improvement activities, which is exactly what the wellness model is trying to do. But it's such a complicated question.
You said that it wasn't a medical comment, there's no medical answer for that. So it is obviously, it's recognised as more of an educational needs in some places, in some communities. I'm coming from the South Energy community myself, so don't ask me how many sugars I have actually. My tea.
But you have really, really nice sweets.
But there's definitely a need of education and a need of being able to send that message out to the communities, whether it's through the GP surgeries, whether it's through the wellness model. And we're still missing a trick because the barriers are still not moving. And knowing the fact that these are the barriers, you know, whether it's the language barriers, whether it's lifestyle barriers, we're still missing the trick. We need to kind of like get on top of that.
Absolutely. So if you look in the detail of the targeting of the wellness model, it's going to where people are. I'm very focused on improving the health of those with the poorest health fastest to reduce those inequalities. And you don't do that through doctor surgeries. You do it through schools and mosques and women's groups and...
Do you have a plan of action to do that, basically, where you are going into schools and other places to be able to kind of carry out those things? Because I've been in council for 2.5 years and I haven't seen it until we've had a few things through CCGs and the Belfast come through in the communities. I haven't had anything specifically focused, so it'd be nice to see you all working to be able to get that done.
When did you last have an update on the Healthy Child programme, Councillor Smage, through Scrutiny? I wonder whether it might be timely to build something in around that as well, because that can cover off some of your questions around school-based activities, the Healthy Child programme, the National Weight and Measuring programme. So there's work ongoing and there's some detail in the report.
Yeah, a couple of questions which are linked. On page 34, you referred to service delivered by Reed Momenta. If you could just say a little bit about that, but the kind of question behind it is we've got reference in the report to the preventative work that your department's responsible for. A couple of services which are commissioned by National Health England, other services which are commissioned by the CCGs, some services which are delivered by Lacala. Where is the kind of coordination in that lot? Because it looks quite sort of disparate and always a danger of gaps developing and things falling down the gap.
Absolutely, and I knew you'd pick up on the Reed Momenta issue, and I don't have a huge amount of detail as to how they came to be the partner that they work with. In terms of the jigsaw puzzle that you describe, I think you're absolutely right. I think there are lots of bits of this jigsaw puzzle, and we need to move ourselves to a much more coordinated. Do we know what the picture on the top of the jigsaw box is? I think we're getting there. I think wellness will play its part in that. I think our increasing integration journey. So Steve Brennan's been recently, hasn't he, to talk to you about the integration. Is he coming? So when Steve comes to talk to you about the integration, I think that will give you some assurance that we are working together to avoid those gaps. I think it's right that some of the services are commissioned by NHS England because they are much more of that kind of treatment approach. But the integration and the wellness model, I think, will get us to be more coordinated in terms of our response.
So the integration and wellness model doesn't focus specifically on diabetes, although there is some relevance there. I just wonder whether there's a need to consider some kind of overall strategic board for diabetes service commissioning and delivery within Kirklees.
Yeah, I'm a little bit reticent to say that we'd have a disease-specific board, because actually the risk factors, if you experience the risk factors for diabetes, they are that you're overweight and you have other lifestyle issues. So the chances are that your risk of cardiovascular disease, coronary heart disease, types of cancers are also increased. So by being too disease-focused, we'd almost add more jigsaw puzzles in than take them out, if that makes sense. So I think a general health improvement, healthy lifestyles, living your best life approach will gain us more than being too specific.
Can we just ask on that point what the Health and Wellbeing Board are looking at in relation to this? Because I would have thought that they should have been looking at healthy lifestyles and health inequalities, etc. So how are they overseeing this?
So there's been some work done recently by a lady called Lucy. She will have a surname. Can't remember what it is. Lucy Cole, thank you. Lucy Cole, to review the health and care plan for Kirklees, and then all of the prevention work will hang underneath that. I haven't taken anything specifically to the Health and Wellbeing Board, but I've only been around for a little while. It is on their plan to bring things through, yeah.
I just want to ask a question. I represent Almonbury Ward, and it's kind of been referred to earlier, Appendix 3, uptake of patients. Almonbury Surgery referred 1 patient, Waterloo Practice referred 72. So are all doctors aware of, of the referral programme? Presumably they are, or is that just perhaps because they've only come across 1 person in the Almonbury Ward, but it's,
There's a flaw in how this data's been presented to you, because actually it shouldn't have been given to you as numbers. It should be given to you as rates, because we've got nothing to compare the sizes of the practice. It might, and I don't know enough about the size of the practice. What you might have is a practice that's only got 10 people in it, and they've referred 7 people, so they've referred 70% of their population, and then you've got one practice that's got 100, they've made 70 referrals, so as a proportion they've made the same. So I can look into that for you in some more detail, but I think it's probably just a bit flawed in terms of how it's been presented.
The integrated foot pathway, is this across the whole of Kirklees that this operates?
As far as I understand it.
We'll check that then, because it's important that there is a quality of service across Kirklees. All right. Are there any other questions on this line here?
Focusing on avoidance and early intervention, is engagement taking place with community groups that support disadvantaged families to obtain lived experience stories relating to the challenges that financial constraints create, both in relation to maintaining a healthy diet and the recommended exercise regime? And just one example of such a community group would be the local food bank, the Welcome Centre.
Trying to write your point down, press a button and speak at the same time, I'll fall off my chair. We've not done any work specifically in public health around those lived experiences, but I think it's a really, really valid point. We give health advice, we give lifestyle advice to people, sometimes fully in the knowledge that it's completely impossible for those people to achieve that. I'll pick that up with Jill actually in terms of the Communities Plus work as well. So yeah, it's a really, really valid point. Thank you.
Thank you.
Just on the diabetic eye screening programme.
Yeah.
Interesting that in North Kirklees it's delivered by Mid Yorkshire Trust and commissioned by the CCG.
Yeah.
Greater Huddersfield it's delivered by EMIS Care and commissioned by NHS England.
Yeah.
And also a comment that the eye screening is not included in the quality outcomes framework and doesn't appear to have the quality data that Foot Care has. So is there a bit of an issue here?
Yeah. I think your previous point about the many pieces that make up this jigsaw, it's a complex. It is, yeah. It's a micro jigsaw. As a slight aside, I'm actually part of the peer review of the eye screening programme at Mid Yorks in the next couple of weeks, because there's a requirement that a consultant in public health is part of that review. And after that, I will understand it in much greater detail. But I think you're absolutely right. We're identifying kind of jigsaws within jigsaws here, and that fractured commissioning provider landscape is very much what we're trying to put back together through the integration work.
Thank you. So I think that point is that we're looking for the best outcomes for people across Kirklees in this area, well, across all areas, but the area that we're focusing on at this moment in time, and the mismatch of providers and etc. I think we would want to have more assurance on that provision of service is equitable and providing the best outcomes. And best practice is shared as well across the systems. That the lived experiences are taken account of, and work with organisations such as the food banks. And we'd also like the Health and Wellbeing Board to look at this healthy lifestyle work and ensure that the outcomes are being achieved. Is there anything else that I've missed? No? Okay, thank you very much. Thank you. The last item on our agenda is the work plan. At the moment, there are no updates to this in October. We will be looking at Mid Yorkshire will be coming with a report on their ambulatory care service in Dewsbury, and we will also be looking at an update on winter pressures. You remember we had winter pressures in January to look at the situation that was emerging in winter, and a piece of work has been done on the learning from that, and what we need to understand is how that will be applied for this particular winter. Okay, thank you very much. That concludes today's meeting. Thank you.